Seroma. Fluid collection related to the serous lymph drainage secondary to the transection of the lymph vessels, increasing infection risk if drained. The treatment. Observation. Consider pressure distressing and needle drainage. Wound adhesion. Disruption of the wound that was primarily closed, causing loss of the barrier of the skin or fascia. Risk factors are local, systemic, technical feature of the closure, excessive tension on the wound, increasing intra-abdominal pressure, and causes opening, hematoma, infection, poor blood supply, radiation, and transverse incision. Systemic: male smoking, malnutrition, connective tissue diseases, immunosuppression, pulmonary disease, ascites, poor nutrition, steroids, chemotherapy, obesity, and others. Diabetes mellitus alone is not a risk. The clinical feature. Typically, postoperative day 1 to 3 or 7 to 10. Most common presentation signs is serosaginous salmon colored drainage from the wound, erythema or leakage of the enteric material. So the wound looks like this color. And evisceration, palpation of the wound edge should normally feel a healing ridge from abdominal wall closure. The treatment. Place moist dressing over the wound with binder around abdomen and transfer to operative room. May consider conservative management with a debridement of the fascia or skin margins. So evisceration is a surgical emergency. Take patient for operative reclosure. And then we have incisional hernia, a late complication of the facial adhesion and failure of the facial closure. GI content are still contained within the sac of the peritoneum. Hernia can develop 6 to 8 weeks post-operatively due to poor wound healing and increasing the stress on the abdominal wall. Symptoms aggravate by coughing or straining. Smaller facial defects such as the laparoscopic port sides have a higher risk of the incarceration. Definitive treatment: surgical repair. Large hernia that pose little risk of the incarceration do not need to be rapid as a minimal change of the bowel obstruction.